recording. Okay, so we're live, so hopefully we'll see some people coming in. Oh, yeah. Hello, everybody. Welcome to the webinar. We're just going to wait a couple of minutes while everyone logs in. We're up to 25 already. Let's see if we know anybody. And in about 1 minute, we'll start the actual presentation with Dr. Truitt. See someone joining from their phone. Hope you can hear us right on the phone. There is a chat function there, guys, for those joining for the first time. If you hover your mouse at the bottom of the screen, there's a Q&A button. Feel free to write questions in there throughout as we go along. If it's an easy one, I'll answer it on the spot. Otherwise, we'll park it and we'll have a question and answer session at the end for Dr. Truitt and Dr Cloete. Okay, we're up to 32 now. It seems to have slowed down, so I think most people are probably in. That are coming in. So, okay, let's get started. Over to you, Skip.
Thank you very much, John. The objective of our webinar today is to show how you can incorporate orthodontics into a general dental practice and how the sophistication of the appliance systems have changed, where the skill level really lies in the doctor understanding the problem rather than the mechanics of treating it. So there are many, many good reasons for bringing orthodontics into a general dental practice. It elevates the level of the practice. It lets you help hundreds of patients you could not otherwise help, such as children with airway obstruction or adults with TMD dysfunction. And then the bottom line from all of that, it increases the overall revenue. So it's really a win-win situation for everyone involved, for the patient, for the doctor, for the practice. It just simply elevates everything to another level. What we're going to do is begin by looking at a very straightforward case, one treated by Dr. Cloete. Then I'll give him a moment to comment on it and what the orthodontics has done in his practice. This particular patient, you can see, has a very, very unaesthetic relationship with the blocked out upper right cuspid. And especially the teenage female, that can just affect many, many things. It affects them socially. Obviously, she doesn't want to smile. It can affect the way they do in school. And then beyond that, she's got an underdeveloped maxilla, which affects her airway and her temporomandibular joints. So typically a patient like this, when they're seen classically orthodontically, it looks like an extraction case, which is not at all. If you look at the vault, you can see the venous pooling. That's from the narrow maxilla and the constriction on the veins and the ethmoid sinus. So we're going to utilize the alpha appliance and level and align and torque and develop the arch, because the orange sagittal and the delta force together can frequently be used in combination. Child has a perfectly normal complement of permanent dentition. As soon as the third molars start to impact, we'll remove those. This is the start of the delta force. I'll show you the ligations in a moment, but everything's in minimum ligation on the upper to start with. And the arch wires are level and aligning and torquing, and they're actually developing the arches transversely. So there's a range of about 3 to 4 millimeters that you can get transverse development. And you can see the venous pooling disappearing in the vault itself. We're moving up in the ligation sequence here, so all the brackets are in the maximum ligation. We get the maximum pre-adjustment out of the appliance. And this is the finish going into retention. So there'll be functional retainers in conjunction with the 3-to-3 bonded retainers. So the treatment time on these cases is usually pretty rapid, somewhere between 12 and 14 months. This particular one came a little under the treatment average. But you can see that's a tremendous change for that short a period of time. And classic orthodontics says you can't do that, and they just simply don't use the hardware that allows them to do that. So you can see all the positive changes that have occurred. Then we have the aesthetic change as well. So not only have you affected her dentally, her airway, and you can see the venous pooling gone beneath the orbits, but you've also had a tremendous impact on her social relationship with her peers. So this is a case that Stefan treated, and Stefan did no ortho prior to us crossing paths. And so I'd like to call on Stefan to make a few comments on what orthodontics has done for his practice. Stefan?
Good evening, everyone. And I want to thank Skip for giving me the opportunity to share my journey through the orthodontics. I qualified 23 years ago, and I specialized as a prosthodontist in 2005. I mainly did prosthodontics and general dentistry. And then in my practice, I kept on seeing these young children with loads of overcrowding in their mouths, at a young age, 6, 7, 8 years old. And I kept on referring these patients to the local orthodontist, who sent those kids back and did nothing for them. And I just thought that there must be something that can be done for these kids to improve the situation. And I was introduced to Skip's courses, and the first course I did was course 1 in 2011 at Heathrow. I attended Skip's first course. Enjoyed the course a lot, and I just decided I'm just going to get in at the deep end. That Monday when I got back, I booked my first patient in, and I must say I'm very grateful for the fantastic backup and support that I've had from Triple O Lab. It's amazing to have support and help you through this, because it is a bit of a daunting task initially. But you got to start with a clinical work as well. And over the next couple of years, I sort of finished all Skip's courses. I did some of the courses I did twice. And I'm really grateful for Skip, help that Skip gave me, Rod and Robert Triple O in Birmingham. And the practice just slowly grew. And in about 5 years' time, we doubled the turnover of the practice, and the patients just kept on growing, and the parents started talking. They talk at school, they tell their friends, and basically it's grown to a point where I'm spending 90% of my time doing orthodontics now. I've got patients flying over from Hong Kong and Italy and Scotland to come and see us, because what we are doing is quite unique, and the patients see the benefit of it. There's a massive need for this treatment, and you can almost in every child you see, if you can identify the developmental problems at an early age, there's a massive demand and need for these kids, and the parents can see the need for themselves. And often a lot of the tongue thrusts and underdeveloped jaws and all that. So the parents actually come and they talk amongst themselves, and that's how you just get more and more patients. And I found that once you explain what you're doing, the parents really get the treatment very early on, because it is so obvious and it just sounds and it is just the right thing to do. And we get a really high acceptance of cases. The parents really understand it easily, and it's a fantastic practice builder. What also really I found is, once you've successfully treated a lot of these children, the mothers and the fathers, they see how the treatment has worked on their children, and they then do treatment themselves. And I ended up in so many families treating the mothers and the fathers after their children has been done. So I must say this way that the treatment has been a massive benefit to me, to my patients. We have a lot of very happy patients, and I can't recommend it enough.
I think you've completed over 750 cases, have you not?
Yeah, we've done at 750 cases by now, and it's since 2011 that I started.
That's just phenomenal. Thank you very much, Stefan. Appreciate it. So what we'll do next is we'll go into a short look at how the bracket system works, because it is pretty unique. And it's what's called a variable force bracket. So one of the mechanical problems with brackets is the friction. And when you get the friction low, where things are moving quickly, you lose control. And then when you get the friction high, you have control, but then it takes a long time to move teeth. So having a bracket that can change in terms of the friction between the arch wire and the slot makes a tremendous difference in what you can do with each case. So when we look at the bracket itself, it's unique in that it has 3 incisal tie wings, a pendulum, tie bars, and then the pre-adjustment is in the base and in the slot. The identification system is pretty straightforward. The angulation is what makes the difference between having a left and right bracket. So because centrals are angulated, there has to be a left and right central. The color code is black and it's on the distal tie bar. Laterals have angulations, so they have to have left and right as well. The color code for them is pink. And then cuspids are the heaviest angulated of all the teeth, and their color code is green. And then one bracket fits all four of the upper bicuspids, left and right, first and second. And the way I tell the difference between an upper bicuspid and a lower bicuspid is the upper bicuspid pendulum does not have a mark, where the lower bicuspid will. Moving to the lower arch, the incisors all fit the same bracket, so there's one bracket for all four, and they're very easy to identify because there's only two incisal tie wings. Lower cuspids are angulated, so there has to be a left and right. Their color code is blue. And then one bracket fits all four of the lower bicuspids, and it has the dot on the pendulum, and that's the difference between the upper bi and the lower bi. So it's a pretty simplistic nomenclature system. The instruments are pretty straightforward. The standard ligature director, ligature remover. It's a double-ended instrument that's reverse curved on either end. It's used to not only take off the ligature elastics, but to make some of the placements. Then the ligations are simply increasing or decreasing friction between the arch wire and the bracket slot. So when I ligate right down the middle of the bracket, I get the effect of a passive self-ligating bracket, like a Damon or a Carriere. And then if I ligate a round wire in, I get all the pre-adjustment with the exception of the torque. And since usually we want the torque, we ligate a square wire in from the very beginning and torque from the very beginning of the case as opposed to the end of the case. As the teeth become closer to normal on the arch wire, we move the ligation up to medium force. And this is like a little triangle around the corners of the bracket. You can see it has the effect of now forcing the wire down into the slot. And this is the same effect of an active self-ligating bracket. So what we can do is just change the effects of the bracket by the way we ligate. And then the round wire again will get all the pre-adjustment except for the torque. Using a square wire, you pick up the torque as well. Then the maximum force is starting in the medium ligation and forcing the ligature under the tie bars. This has the effect of a big twin slot bracket, giving you maximum control. And again, if it's a round wire, you get the pre-adjustment with the exception of the torque. Square wire, you pick up the torque as well. And then when you want additional torque, you can actually change the wire to rectangular. So we'll look at the arch wires as a separate issue. So to get the maximum ligation, you start in the medium ligation, use the ligature remover, and force it under the two tie bars. I can do a maximum ligation on one side and a minimum ligation on the other, and I create a rotation ligation, either one direction or the other. So if a particular tooth needs additional rotational force, and this takes the place of something like a rotation wedge. So in this case, it's pulling from the underside of the tie bar, pushing on the opposite side. Then when I want to anchor ligate, I use the V ligation, and this increases the friction to the point that the bracket cannot move along the wire. So many times I can avoid having to steel ligate by just moving into the anchor ligation. So you can see how it's forced against the wire. Typically, you're doing that with a rectangular wire to get the maximum anchorage. So we'll look at the arch wires as a separate issue because there's very little bending of the wires in the newer techniques. Arch wires come upper and lower. This relationship of the lower being slightly smaller than the upper is called correlation. So I buy all of my different gauges in upper and lower, and they're just simply one larger than the other. So when we talk about arch wires, they come in two different classifications. Wires that flex, something called austenitic arch wires, and this is standard steel or standard nickel titanium. And then wires that are affected by temperature, they're called martensitic. And when I chill the wire to a certain point, it becomes totally plastic. And then as it warms towards the body temperature, it starts to resume its form on the Roman arch. So these are the wires we're normally using for leveling, aligning, and torquing. So the austenitic wires have yield points, loading curves, unloading curves, And that's what causes standard arch wires to be so long in the treatment, is you have to start with very small wires and progressively move to stiffer wires. With Martensitic wires, we don't do that. So the more you flex a steel wire, the heavier the force. To a point it bends, that's a yield point. Standard nickel titanium is just more flexible. Super elastic nickel titanium is still more flexible yet, but they all have these loading curve, unloading curve, and yield points. Whereas if I move to austenitic wire and I compare the difference at 8 degrees Celsius, the wire is totally plastic. As it warms towards body temperature, it starts to resume its arch form. And then just above body temperature, it starts to become austenitic. So that particular technique or that concept eliminates the position of the tooth being a critical issue. What still remains is teeth in the anterior region that have less root structure than teeth in posterior need much less force. So the next step in the technology was to use multi-graded wire. So anteriorly, where I'm dealing with incisors, it's about 100 grams. Come into the cuspid, bicuspid region, it moves up to 200, and into the multi-rooted molars up to 300. So by using the proper nickel titanium austenitic multi-gradient wires, we can rapidly move teeth and still not resorb roots with absolutely no discomfort to the patient. The upper arch wires have a little larger stop. This prevents them from coming out of the appliance. So the interslot distance between the centrals is greater than that of the lower centrals. And so it's easy to tell the difference between the upper and lower arch wires by the size of the midline stop. And those stops are placed with the open portion of the stop incisally. Then my starting wire most of the time is going to be a 20-20 square. It's multi-gradient, thermal activated nickel titanium. And then the corners are beveled, so if the wire gets caught in one corner of the slot or the other, rather than lock, it simply ratchets. And each time it ratchets, it torques the tooth a little more and a little more. So it's just unheard of in most techniques to start with an arch wire that large and it be square on top of that. But by having the proper arch wire and the proper ligation of the bracket, we can start with a larger wire and treat very, very rapidly, torquing from the very beginning. So my arch wire gauges are 20-20 square upper and lower. If I don't want the torque, I start with the 018 round upper and lower. And then when I want additional torque, I move up to the 019-025 rectangular. So it's really a very small number of arch wires required to treat the average case. We'll look at another patient, again, one treated by Stefan, because I tried to select patients for you that were treated by someone I'd trained rather than by myself, so you can see the benefits of how it can affect your practice. But this young man, you can see, is going to have a lot of aesthetic problems involved. You can see the venous pooling beneath his orbits again. That's very common in the patient with a narrow maxilla. You can see the venous pooling in the vault again. Full complement of permanent dentition. So typically we try to wait till the second molars have erupted before we start into the delta force, unless there's a mechanical issue that prevents that. So what we're seeing here on the top picture is something called a Ric Inator. It's a fixed bite ramp. So as we're leveling, aligning, and torquing, we have a fixed bite ramp in, and that lets me start to ramp the mandible down into the class 1 and open the vertical dimension. And then if the inner canine width is narrow, the laboratory incorporates an expansion screw in the Ric Inator, and the parent can turn the gear, which increases the upper inner canine width. You can see we're in the 20-20 square thermal wire that's multi-gradient. So just a beautiful example of how efficient the appliance can be. And we're in the functional retainers now with a bonded lingual 3-3. You can see the tremendous change in the alveolar base. The venous pooling gone. Tremendous improvement in the child's aesthetics. So Stefan learned well. Another patient, sorry, let me back that one up here. You can see the same venous pooling beneath the orbits. You know, she's going to have a narrow maxilla from the ugly duckling effect through here. We'll talk a little bit about that on this patient. So this is not a good candidate for the delta force. This is an orthopedic case followed by the delta force. So this particular child is going to have both arches developed well, mandible brought into a full class 1, and then the delta force simply refines the occlusion in the class 1 position. So when we're taking radiographs in the mixed dentition, we want to repeat the radiograph about every 18 months until the second molars have erupted. Waiting 3 years, too much can happen on the developing child. Then once the second molars erupt, we drop back to the every 3-year treatment time. The other thing I want to do is after I've completed the development of the maxilla with whatever appliance, I want to take periapical radiographs and determine the position of the permanent cuspids at that point. Because as the laterals erupt, the permanent cuspids should be vertical to the deciduous cuspids, and at least a third of the deciduous cuspid root resorbed. So my little checklist for children on the panoramic radiograph, I want to be sure of all the permanent teeth, be sure I don't have any congenitally missing teeth like second bicuspids, correct sequence of developing, so things should be happening in the correct sequence, not necessarily chronologically. I want to check for retained deciduous teeth. That causes the underlying teeth to rotate. Check for neoplasms, impacted teeth, and that's how I want to be sure I know exactly where those maxillary cuspids are. So those are two things I do a little bit different on the mixed dentition patient than I do on the permanent. This is an example of an upper 3D Swartz. Turned sagittally, it corrects the division 2. Turned transversely, it develops the arches transversely. This child had an anterior tongue thrust, so we modified the appliance with occlusal coverage of acrylic, tongue wires, and spinner. And we have to teach the child to learn to swallow with the muscles of mastication using the trigeminal nerve, as to what they're doing now, swallowing with the muscles of facial expression and the facial nerve. So the key there is to teach the child to swallow with the teeth together. The lower appliance is a Williams, and it simply allows the parent to turn the gear at the appropriate time for the width, and then the lingual wire incorporated within the appliance distal drives and recovers the lost lower arch length. Then it's very, very common once we have everything perfectly balanced in the mixed dentition to go in with a lingual arch on the lower that holds the lower space of Nance and a simple upper Hawley retainer. We just modified this one with the tongue wires and the spinner to help the child keep the tongue thrust under control. And what we do when we finish with the delta force is we have the bicuspids in, we then bond 5 to 5, leaving the lingual arch in position. That allows me to use some of the space of Nance to get an ideal relationship anterior to the first molars. Then I simply take the lingual arch out, and within a month, function will mesial drift the remainder of the space of Nance. So that's exactly what we've done with this child. You can see we're in the minimum ligation on the 2020 square wire. This is the starting for that being into the delta force. The only brackets that have medium ligation are the 4 lower incisors. Using vertical elastics to give the canine guidance. We've got a Ric Inator to open the bite. Vertical elastics posteriorly to super-erupt the remainder of the deep curve of speed. So really the mechanics are very, very simple with the newer hardware. Then as we go into retention, if aesthetics is an issue, the functional retainers can be made almost invisible, something called a clear bow retainer. The idea is I want to get anything interfering with the occlusion out during the functional retention stage. Just another beautiful end result. So Stefan, feel free to comment on any of these cases if you see something you'd like to mention. It's just got to excite you. You can do that for a child. Taking a child that normally would be a 4 bicuspid extraction case, turning into a beautiful end result, normal joints, normal airway, normal growth pattern. And Stefan was absolutely correct. Parents learn that. They're their best advertising. Absolutely the best. Beautiful change in her facial aesthetics. Change the whole woman's life. And if you really look carefully, you can see the orbits leveling. That's the cranial sutures balancing. Shape of the orbits changing. Corners of the mouth leveling. Just so much going on that as we get deeper into it, I can explain to you in more detail. So what I'd like to do is extend an invitation to all of you to join us in the seminars. If you've already had one of the seminars, I keep them constantly updated. And so you probably had a seminar a year or so ago. There are quite a few new things in each seminar, and the laboratory has a discount on retaking the seminar. And if you're a new person just starting out, I can take you from knowing nothing about orthodontics to another level. So it's been a pleasure working with you. Thank you from Texas for the opportunity. And what I'd like to do now is turn it back over to John and let him do the question and answer series, and Stefan and I can help you with any questions that you might have. And there is my personal contact, so if you would like to ask me about a case or send me a case you've got in progress, you can contact me through the skip@cfoo.com. So our upcoming seminars will be at Heathrow. This is the schedule for them. And so I'll turn it back over to John and let John start the question and answer series. John?
Okay, thank you very much, Skip and Stefan. Very informative. We have a question here from Anonymous. Could you please repeat the mixed dentition detail with regards to the lateral that erupt and the specific root resorption of other teeth and cuspids?
I can do that. By the time the permanent laterals erupt into the arch form, the maxilla should be the normal size. So up to that point, it's growing in size. But the time the maxilla, the permanent laterals, if everything's normal, the maxilla should be the right size. If the maxilla is the right size, the permanent cuspid should be vertical to the deciduous cuspid with at least a third of the deciduous cuspid root resorbed. If that hasn't occurred, like the maxilla previously being narrow, many times when you get the maxilla the correct size, the upper cuspids are trying to impact. So what one does at that stage is simply extract the deciduous cuspids, use a number 8 round burr, bone cutting burr, slow speed, surgical shank, surgical fluke, and you use the extraction site to access the crown of the permanent cuspid, removing the follicle and any bone occlusal to the height of contour. And then the cuspid will just literally turn and come through that trough and erupt into a normal position. So all the research shows that if you do that at that particular point in time, you can avoid the impaction of the permanent cuspid. So that's the objective, really, to avoid the impaction.
Fantastic. I hope that answers your question on Anonymous. Just a quick note, if you book through this course on the website, you won't see a 10% discount button anywhere. It's just the $999 price. However, anyone that books on it, I'll just knock the 10% off automatically. So you can either call me on that number there, you can email me, or you can go to www.oodentallabs.com. You can book on there. If it's not showing the 10% discount, don't worry, we'll knock that off. So you just pay a £200 deposit now, then the balance between. I can't see any more questions coming in, so unless anyone's got a burning question now, what I will do is I've recorded this webinar, and it will be available to watch again, and I will share on our Facebook page and our YouTube channel. So please follow our Facebook page and keep up to date with other webinars that are coming up. We haven't got a topic for our next webinar next, so if you've got anything you'd really like covered, please let us know. If not, I suspect we'll do one on TMJ, probably in a month's time, something like that.
Sounds like an excellent idea. Thank you for joining us.
Thank you very much, Stefan. Thank you very much, Skip, and thank you all for attending. Good night.
Good night from Texas.